What's the objective?
It is based on a 6x6 into 6 strategy. There will be six
What is the
beneficiaries.
main aim? That is okay. That is the thing. What is the objective? Why did they started this? Why did they start this Anemia Bharat program?
Reduce the prevalence of anemia by 3
Anemia.
Excellent,
percentage
excellent.
every year.
From 2018 to 2022. By this time, we should have accomplished. So the strategy is 6x6x6 strategy. 6 beneficiaries, 6 interventions, and 6 institutional mechanisms. Anybody who are the 6 beneficiaries? Anybody remember?
Ma'am, the children between 6 and 59 months of age.
Okay.
Children from 5 to 9 years of age.
Okay.
And adolescent girls and boys from 10 to 19 years of age. Women of reproductive age belonging to 20 to 24 years. And then pregnant women.
20 to
and then
49. 20 to 49 years of age.
40, okay.
Pregnant and lactating mothers.
Pregnant women and lactating.
Okay. So these are the 6 beneficiaries. From 6 months, it starts. For females, it is up to 49. And for boys, it is up to 90. So 6 interventions, how to remember? So prevention is always better than cure. So how do we start? We start the prevention strategy from the birth itself with a delayed cord clamping. Then we are giving the prophylactic iron and folic acid tablet. Then we give the deworming. We test and we provide the treatment tablets. We provide the tablets and also we address the non-nutritional causes of anemia. So these are the 6 things. Okay. So I go to the next question. Analyze the following HPLC report of 11 months old boy who presented with failure to thrive, transfusion-dependent anemia, splenomegaly, and hemolytic phases and answer the following questions. So hemoglobin A is 14.7%, hemoglobin A2 is 45.5%, and hemoglobin F is 37.7%. I'm extremely thankful to my colleague, Dr. Vasanta Malar ma'am, for sharing this case. So have you noted all these things? Shall I go to the questions?
Yes, ma'am.
What is the principle behind HPLC? Analyze the report. What would be the possible diagnosis? What would be the appropriate next step? We are having this patient with us in Teni.
HBE.
No, first question.
Once.
What is the principle?
Chromatograph.
Actually, it is based upon what is called as the retention time. So different substances have different retention time in the chromatography, how long they stay in a path. So certain hemoglobin like hemoglobin A2 and hemoglobin E have the same retention time. And in HPLC, the peak will be a combination of these both. That is HBE and HbA2. Okay. So this is the principle is the retention time. Based on the retention time. So here, 2 molecules, hemoglobin A2 and hemoglobin E, being having the same retention time, they will represent the same peak. Okay. Then analyze the report. The Lenna diagnosis, which is very high.
HbA2.
A2 is 45.5. What is the normal, what is the maximum HbA2 in thalassemia trait? It's up to 4.5 to 5% only, but it is more than 10% of the thalassemia trait value. So it is not thalassemia trait. Also, we have an elevated HbF also. We'll go. So each type of hemoglobin has different retention time. So HbE is interpreted by analyzing the HbA2 as they have the same retention time. So here you see, normally level of HbA2 may be up to 10 in the case of beta thalassemia carrier. Whenever it is more than 10, so it is something different. So we have to see whether HbA is present or HbF is present more than HbA. In case HbA is present, but HbF is not elevated, it can be 2. Either it is a E trait, HbE trait. What is hemoglobin E? Anybody? What is the mutation there? Where is the mutation?
Beta globin chain at the 26th position.
Beta chain, 26th position, what happens?
Glutamic acid will be replaced to lysine.
Excellent. So either it could be E trait or E beta plus. So here HbA will be less than HbE in case of beta plus. But look at here, there is a hemoglobin F and this hemoglobin F is more than hemoglobin A. So it can be either a homozygous E or it could be E tal, E beta 0. So the possibility is E beta 0 because homozygous EE will be asymptomatic. Here, the patient is symptomatic, having failure to thrive, splenomegaly. So the next will be capillary electrophoresis, which differentiates this HBE and HbA2. Okay, this is an image-based diagnosis. You look at the image and answer the questions. Face la edavadhu iruka? Arm la, forearm la, palm la. Can you appreciate something is wrong here?
Limb abnormal.
Which limb? Which area of the limb? Upper limb.
Forearm.
Forearm. Okay. What's the diagnosis?
Fanconi.
Fanconi. Priya? Priya, do you want to answer?
TAR.
The TAR.
What? Is it Fanconi or TAR?
TAR, ma'am.
TAR. Why do you want to say TAR? Why do you want to say Fanconi? So whenever you know that there is a radial abnormality, right? Radius, absent radius. So whenever you suspect absent radius, the next thing you have to look is the thumb. Whether the thumb is normal or abnormal. If the thumb is normal, then it must be TAR syndrome. When the thumb is abnormal, then it could be either a Fanconi or it could be Holt-Oram syndrome.
Holt-Oram syndrome.
So what are the two investigations you would do immediately?
Plus EBC for platelet.
Okay. Name two differential diagnoses. I have already told you. What is the natural history of the disease and explain the etiology. What is the etiology here? Shall I go to the answers? So now you can see the radius. Okay. There is radius absence. So TAR syndrome, you will do X-ray and CBC with peripheral smear. These are the two differential diagnoses. And thrombocytopenia is very severe in infancy, causing life-threatening bleeding. Bleeding becomes less severe later on. And cow's milk protein intolerance is very common. Can you tell me another condition where cow's milk protein intolerance and thrombocytopenia is common? It presents like dysentery, presents as CMPA, but not actually CMPA. And also there will be thrombocytopenia. Wiskott-Aldrich syndrome.
Wiskott-Aldrich
syndrome. It presents like cow's milk protein intolerance. Explain the etiology. Is a genetic etiology, RBM8A gene involvement. So clinical skill demonstration. This is actually very theoretical. Nobody is doing all these things. But since for DNB people, there is a station on clinical skill demonstration and I want you to answer. What is the surface marking of drop space? What are the various clinical methods to detect enlargement of spleen? Can anyone tell me drop space surface marking?
Yes. Bounded by anterior axillary line and sixth rib.
Okay. So we have 4 marks. This is 6th rib at the costochondral junction. And we draw a perpendicular line till it meets the costal margin. And what is this point? This is called Castell's point. So Castell's point is lowest IC space in the anterior axillary line. So here it is 9th rib at the anterior axillary line. So 6th costochondral junction and anterior axillary line. These are the 2 things you need to remember. Join everything, there is a semilunar space. So what are the various methods you palpate or percuss to detect the enlargement of spleen? So one is Middleton's maneuver, another one is Nixon's method and Castell's method. Castell's method is based upon this Castell's point. Okay. So a 5-year-old baby boy who had already been diagnosed with sickle cell anemia presents with fever, cough, breathlessness and chest pain. His SpO2 is 95% under room air. His chest X-ray shows left homogeneous opacity with obliteration of the costophrenic and cardiophrenic angles. There is minimal opacification of the right lower zone also. 1 month prior to this episode, he had been treated for dactylitis. Okay, is the scenario clear? Can I go to the questions?
Yes, ma'am.
Yes. What is the most probable acute diagnosis? What is the most well-known cause for this event? What is the most frequent preceding event of this emergency? How will you manage this patient? Will be blood transfusion indicated? How can you prevent these episodes? Name few newer drugs to treat the underlying condition. That is sickle cell anemia. What is the diagnosis? I think this is very clear.
Acute chest syndrome.
Acute chest syndrome. Very good. Very good. Next question. So this acute chest syndrome, most common involvement will be the left lower lobe. Sometimes multiple lobes also may be involved. Okay. What is the most well-known cause for this event?
Thrombosis.
It is an infection. Infections precipitated by pneumococcus, mycoplasma, or chlamydia. The most frequent preceding event of this emergency. So I have given one clue to you, dactylitis.
Yes, ma'am.
What does dactylitis cause? It causes pain. It presents with severe pain. What do you use for that pain crisis? You use opiates. So usage of opiates in a case of pain crisis is one of the precipitant or one of the preceding cause for this acute chest syndrome. But this does not prevent you from using opiates during the pain crisis. Don't fear that using of opiates may precipitate acute chest syndrome in the later date. So I'm not going to use, no, not such that. So it never warrants excluding the use of opiates. How will you manage this patient? When will the blood transfusion indicated in this patient? How can you prevent these episodes? So what will you give? Will you give antibiotics or not?
We have to give
antibiotics.
Broad spectrum
What are the preferred antibiotics you will give?
Oral penicillin.
Oral penicillin. So you are dealing with pneumococcus, mycoplasma, and chlamydia here.
You have to add clarithromycin to the regimen.
Why not azithromycin?
Macrolides.
Ceftriaxone and azithromycin. Oxygen is indicated when SpO2 is less than 90%. What is the saturation here? It is 95. So once it drops more than 4% or if it goes less than 90, we give oxygen. Blood transfusion is indicated when there is decreasing SpO2, increasing respiratory effort, drop of hemoglobin more than 2, or a previous history of acute chest syndrome. And in patients with any pain, how can you prevent these episodes? Regular use of an incentive spirometer at 10 to 12 breaths every 2 hours can reduce the frequency of acute chest syndrome episodes. So even in the dactylitis period, we could have used this incentive spirometer. Name few newer drugs. So 2 drugs have been approved for pain crisis. One is oral glutamine. It is a dilator, right? Vasodilator. So in any vaso-occlusive crisis, we can use this, approved for more than or equal to 5 years of age. Crizanlizumab, it is approved for children more than or equal to 16 years. It is given IV monthly and it is a p-selectin inhibitor and prevents the pain crisis. And voxelotor, it lowers the polymerization. Lowers the sickle cell polymerization. And these 2 things are gene therapies. Here we are doing gene editing and here we are doing gene addition. Anybody, which gene exactly prevents or inactivates the HbF production? This is very important, right, in the management of thalassemia or sickle cell anemia. Because when there is a high HbF, the symptoms are less. So whenever we increase the HbF, we can give some relief to the patients. So what is that gene? It is BCL11 gene. So that is normally inactivated. Here, this gene, the gene is actually activated after 6 months. When we inactivate the gene, we can cause some gene editing. And this gene addition is, we are adding beta ATH7Q. So these are all the new additions in the latest Nelson. Please go through it. So before going to the question, I want you to analyze this and what is the mode of inheritance. The path on, you have to recognize this once you see this. So who are affected here?
Males are affected, females are affected.
Is there any male-to-male transmission? Not documented.
Not documented.
Okay. So who is this? Round with a dot in the center. What does it represent in pedigree? It represents that obligate carrier. This female is a obligate carrier. So the disease, we are in hematology, some X-linked. And you can see the night movement, like in chess, how the night moves. It's a oblique transmission, not a horizontal. Oblique, can you see? It is like a night movement. So X-linked recessive disorder. Now, she is coming to you for counseling. She has lost 2 maternal uncles for a bleeding disorder, probably hemophilia. This is her brother, and now he is on regular drugs and again bleeds into the joints. She is going to get married and she has come to you for genetic counseling. What will you do? Shall I go to the question answer directly? So after introduction, you have to explain the mode of inheritance. She is maybe a carrier mother. So first thing we need to do here is we have to document the activity, factor 8 activity. Even females can have less than 40% of the activity and they can go for a bleeding. Sometimes even when the females have a normal factor 8 activity, 25% of them have a bleeding tendency. Suppose if she is a carrier mother, how will you document that she is a carrier mother or not? We have to do a gene thing. One is F8 pathogenic variant. So we are not going into the whole genome sequencing. We are just talking about the targeted gene. So here, factor 8 pathogenic variant, we are analyzing the intron 22 inversion first. This is very common. Suppose if it is there, then we can explain her that you are a carrier and there you have a 50% chance of transmitting this defective gene to the your daughter or son. If it is a daughter, she will be having a 50% chance of being a carrier. If it is a son, then it is a 50% chance that he may get affected. Suppose the person is having F8 pathogenic variant. If it is not detected, then we have to go for the whole F8, factor 8 gene sequencing or MLPA. Only after these 3 tests, you have to tell her that you are not harboring this defective gene. And then also we have to test her. So this is how you have to do a genetic counseling. This is the complete genetic counseling in a case of a female who comes to you seeking advice regarding her further pregnancy. So this is the last question. A 3-year-old boy presents with short stature. He had 4 to 5 admissions in the past for pneumonia, skin infections, and otitis media requiring IV antibiotics, and also multiple OP visits for periodontal diseases. His CBC shows hemoglobin of 8.2, WBC of 4,800 with P20, L78, M2, platelets of 1,01,000. The child also had episodes of loose and bulky foul-smelling stools for the past 6 months. X-ray chest shows osteopenia, flaring of the anterior ends of the ribs. The child had not received any transfusions in the past. Okay? Is the scenario clear? Can I go to the questions?
Yes,
Short stature, multiple admissions for infections, now having some enteral manifestations and some bone manifestations. What is the most probable diagnosis?
Schwarzman-Diamond.
Why do you say so?
Characterized by inherited bone marrow failure with exocrine pancreatic insufficiency along with the skeletal malformations.
Excellent. But in the real life, it will not present with all these 3 things. The triad will not be seen. But here, once you see these things, what is a pattern? So here, there is a sinopulmonary infection, also periodontal diseases. Again and again, the child is getting admitting and also requiring IV antibiotics. This tells you that it is an inborn error of immunity. Which arm is involved here? It is mostly the neutrophils. So look at the neutrophil count here. Out of 4,800 cells, only 20% of neutrophils less than 1,000. So the child is having a moderate neutropenia. So this is a signature disease of the neutropenia. So the child may present only with this in the early life and also short stature. And this tells you that it is an exocrine pancreatic defect. And why there is osteopenia? This is because of the medullary dysostosis. So these are the triad of Schwarzman-Diamond syndrome. 2 differential diagnoses of this condition, Sharon?
Diamond-Blackfan or
that is pure
Diamond-Black.
exalaplasia. There won't be any pancytopenia. You have to talk about the inherited
Pearson
bone marrow failure.
syndrome.
Excellent. Pearson syndrome. How will you differentiate Pearson from this condition? I have given a clue also.
Neutropenia.
Yes, neutropenia is prominent in Schwarzman diamond, whereas Pearson has sideroblastic anemia requiring blood transfusion. How will you confirm the diagnosis? You go for a targeted gene panel for SDS. What is the most dreaded complication of this condition?
The malignancy.
Which malignancy?
Myelodysplastic syndrome.
Myelodysplastic syndrome, or they can go for leukemia.
AML.
So myelodysplastic syndrome at 18 years of age, leukemia by 30 years of age. So how will you follow them up?
Depending upon degree of neutropenia, and you have to do serial counts CBC and the 6 months to yearly bone marrow.
Yes, you have to do 3 monthly CBC or a peripheral smear and then bone marrow every year. How will you treat this condition now? Now they are not having any leukemia or MDS. So here we have to give pancreatic enzyme replacement. What will you give for neutropenia?
GCS.
Yes, granulocyte colony stimulating factor. And thank you so much for the patient listening and participation.
Thank you, ma'am.
Thank you, ma'am.
Swati, ma'am? Any doubts in the class, PGs? Any doubts?
No, ma'am. Thank you.
Hello? Ma'am, I think Murugesh sir?
நீங்க முடிச்சிட்டீங்களாப்பா?
முடிச்சாச்சு சார்.
பாதிங்க லெஃப்ட் ஆயிட்டாங்க.
ஓ.
கரெக்ட்ல அவங்க கிளிக் பண்ண மாத்தி பட்டன் அமைக்கிட்டாங்கன்னு நினைக்கிறேன்.
மேபி சார்.
இல்ல கரெக்டா இப்பதான் சொல்லவும் டக்குன்னு இதாயிடுச்சு.
ஓ.
மிஸ்டேக் ஜாயின் பண்ணிட்டேன்.
இல்ல சார் இன்னும் ஜாயின் பண்ணலாம்னு நினைக்கிறேன் நான்.
இல்ல ஜாயின் பண்ணிட்டாங்க.
இல்ல சாரி, I wasn't able to share that, so I just
visible madam.
Yeah. Yes. Good evening everybody. And I have very little actually. I've finished most of my OSCEs last time. But if we can just look at what we did last time. Sorry. Oops, just one second. Yeah, so we'd done we were actually doing statistics and epidemiology when we stopped, and we had covered measures of central tendency like mean, mode, median. We had looked at box and whiskers plot and how to identify outliers. We'd calculated some incidence, prevalence. We had done some probability calculations. And we looked at 3 different types of studies. That is cross-sectional study. We looked at prevalence ratio, prevalence odds ratio. We looked at cohort study, looked at risk in exposed, risk in unexposed, and how to calculate risk ratio. And we also looked at case control study and looked at how to calculate odds ratio. I have a few more things to cover in statistics. So let's look at the next OSCE. A study in Uganda assesses the performance of a rapid diagnostic test for influenza. 82 symptomatic patients with suspected influenza had the test. Results were compared with PCR, which was a gold standard. 59 patients had a positive PCR, of which 43 were also positive by the rapid test. And 21 samples tested negative for influenza by both the tests. So here we are going to try and calculate sensitivity, specificity, positive predictive value, negative predictive value. Look at the diagnostic accuracy of the test. You need to tell me if this is a good screening test based on what you calculate. And the study researchers want to arrive at a best cutoff value for the rapid test. I want you all to tell me how they can do this. So now to begin with, this is the data that we have available. And with this data, I'd like you to first do a 2x2 table. So anywhere when we are looking at sensitivity and specificity, our first thing that we need to do is get your 2x2 table right. So can somebody tell me how to build this 2x2 table? Remember that always disease comes here and the test comes at the side. So if you get this correct and you write your ABCDs, you will get everything in order. So somebody, can you tell me how you will build this 2x2 table? The first piece of information that we have here is that 82 symptomatic patients with suspected influenza had the test. Where will you put this? Tanya, Shahrukh, Priya? You can hear me, right?
Yes, ma'am.
Yes, Arvind. Can you tell me where to put the first piece of information that we have? That is 82. 82 symptomatic patients had the test.
Total.
Yeah, it's the grand total.
Grand
Okay.
total. Yes.
Okay, so it is A plus B plus C plus D. And there you have 82. What is the next one? Results were compared with PCR that we've said. And 59 patients had a positive PCR. Where does that come? PCR is a gold standard, and 59 patients had a positive PCR.
Disease positive total.
Total disease positive. So you have 59 sitting there. Okay. The next point that we have is 43 were also positive by the rapid test. So where will 43 come?
Test positive.
Sorry, which one? A, B, C, or D?
Test positive and disease positive. A.
Okay. A. Okay, so you have 43. And what is the last piece of information? 21 samples tested negative for influenza with both the tests. So where will that come?
D.
Sorry? You're right. D.
D.
Yeah?
D.
Yeah.
Yes, ma'am.
Okay. So this is the information that has been given to us. Now, is it easy for us to build up the rest of the table?
Yes, ma'am.
Yeah.
Yes,
So,
ma'am.
all we have to do is here, 82 minus 59 will give us 23 here. Here you can put in 16, that is 59 minus 43. 23 minus 21 is 2 here. And you get these grand totals. Okay. So remember always that when you're doing all these sensitivity, specificity, predictive value calculations in diagnostic tests, remember to get your 2x2 table ready first. So now let's go on to the questions. Can somebody tell me what is sensitivity, specificity, positive predictive value, and negative predictive value for this? We don't have to do full calculations, but just tell me what by what. What is sensitivity?
Sensitivity is A divided by A plus C.
Okay. So remember, sensitivity is always for disease. Okay. So the true positives divided by all the disease positives. So 43 divided by 59 and you get 73%. What is specificity, Priya?
21 divided by 23, ma'am.
Okay, so it is the true negatives divided by all disease negatives. So that's 21 divided by 23, which is 91%. What about the predictive values? What is positive predictive value?
Positive predictive value is 43 divided by 45.
Yeah, so you go in the horizontal direction. You go by the true positives divided by all the test positives. Remember, the predictive values actually give us the diagnostic power of the test to either pick up true positives or true negatives. So here you have positive predictive value, true positive divided by all test positives. That is true positive and false positive, and it gives you 96%. What about the negative predictive value?
21 by
20.
37.
Excellent. Okay, so 21 divided by 37. That's true negatives divided by all the test negatives. Remember, sensitivity and specificity are the ability of the test to correctly identify either the true positives or the true negatives from all those who have the disease or don't have the disease. But the predictive values have to do with the diagnostic value of the test. So how many of the true positives are picked up as positive by the test? How many of the true negatives are picked up as negative by the test? The next question is, what is the diagnostic accuracy of the test? Somebody?
Yes.
What is the diagnostic accuracy of the test? I've changed my slides a little bit because I didn't. Sorry, Arvind, come again. Anybody? What is the diagnostic accuracy of the test? So basically, this is the proportion of all the test results which are correct. So what all are correct in this? Which numbers are correct in this 2 by 2 table? Which are the correct values? It will be the
43 and
43 and
21.
correct.
21.
So the true positives and the true negatives. So it is 43 plus 21 divided by total, that is 82. And that gives you 78%. This is what is called the diagnostic accuracy of the test. Now, I want somebody to tell me, is this a good screening test? Before that, you can look at sensitivity is 73%. Specificity is 91%. These are the predictive values. This was the diagnostic accuracy. This was meant to be a screening test, right? The gold standard is a PCR. So this was meant to be a screening test. Is it a good screening test?
Oh, ma'am. Screening test should be based on sensitivity.
Okay. So generally, if you have a good screening test, what will you have?
Sensitivity should be high, but specificity can be low also.
So what does it mean? Having a high sensitivity, what does it mean?
The chance of picking up the disease and the positive predictive value should be.
No. Sensitivity and positive predictive value are two different things. So what you said is correct.
Chance of missing out a disease should be low.
Missing out.
Yeah, so you can have false positives, but you don't want to have any false
negatives.
Okay, so a screening test will have a very low threshold to pick up everything that is positive. So you might have a lot of false positives that are being filtered into that screening test, but that is okay because after that, the definitive test that you do should have a high specificity. So you're right, this is not the best screening test that you can have because here the specificity is actually higher than the sensitivity. And generally, screening tests should have higher sensitivity. So remember the SNOUT and the SPIN acronyms. Basically, it is a sensitive test when negative rules out the disease, and it is a specific test when positive rules in the disease. So always remember SNOUT and SPIN. So now the study researchers want to arrive at a best cutoff value for this rapid test. How can they do this? So we said it's not a very good screening test. So how can you kind of change this around and make it really good to screen? What can you do to get the best cutoff value so that it is a very, very good screening test? Shahrukh? Priya?
No idea.
Under the
Okay, Priya?
curve, that's a -2 standard deviations.
Excellent. Excellent, excellent. So you need to not standard deviations, but yeah, you try and draw the receiver operating characteristic, which is a ROC curve. Okay, and this is how an ROC curve looks. So you put the true positive rate, which is the sensitivity on the y-axis, and the false positive rate, which is 1 minus specificity on the x-axis. And then you try and get different values so that basically the best test would have, no false positives and all true positives. That would be your best. But obviously, you won't get a test like this, which is denoted by the purple line. But you try and get as close to this corner as possible. Now, this test had a sensitivity of 73% and specificity of 91%. So 1 minus specificity would be 0.09. And therefore, it would come somewhere here, which is okay still. Like we said, you would love to have a screening test which has a very, very high sensitivity, but this is not too bad. In your ROC curve, this comes here. Is this clear? Any doubts here?
No, ma'am.
Okay. So now we'll move on to the next OSCE, which is a randomized control trial. So here researchers have conducted an RCT to evaluate the effectiveness of a new honey-based cough syrup in children. 200 children aged 2 to 12 years with acute nocturnal cough due to upper respiratory tract infections have been randomly assigned to either receive the honey-based syrup, which is the intervention group, N equals 100, or a placebo syrup control group, which is N equals 100 again, for 3 nights. The primary outcome of this research group was the frequency of nighttime coughing, which was measured by a validated parent-reported scale. And the researchers also collected data on sleep quality and side effects of the drugs. Okay. So now the first question, I'll call out one by one. Priya, the intervention group has reported fewer coughing episodes, mean equals 3.2 episodes per night, compared to the control group where the mean is 4.8. Which statistical test do you think would be the most appropriate to compare these means between the two groups? So here you're comparing means.
Student t-test, no?
Okay, yeah. So the independent t-test, because you are comparing between two independent groups with continuous data. Okay. Shahrukh, when analyzing the occurrence of stomach aches, so here is a side effect we said, either present or absent between the two groups, that is the honey syrup and the placebo groups, which statistical test would you use?
Since it is a non-parametric or qualitative test, we can go for chi-square.
Okay, so here you have dichotomous outcomes and you can do a chi-square test. Okay, so you're just comparing yes or no between the two groups. Again, two independent groups. Very good. Now, Arvind, in pediatric trials, here we said this is a randomized control trial. Why is randomization especially important? Can you name 2 benefits of randomizing in pediatric trials? Sorry, Arvind, you're breaking.
So that the group contains individuals from different
yeah,
with
so
all the
so that is a
characters
basic principle of randomization. But why is it especially important in pediatric trials? That was a question. The basic principle of randomization is that you have two groups
Selection
that
bias.
contain, you're free of bias, that contain similar individuals. But why is it especially important in pediatric trials? In which characteristics do you think randomizing would be helpful?
Allocation or a known and equal chance.
Yeah, so why pediatric is the only question. Okay, so basically, remember pediatric population, there could be developmental, age-related variations. Okay, so and you can also distribute the parental or the caregiver factors like care-seeking behavior evenly between groups. So this is kind of unique to the pediatric population. Okay, so the next question is, during the trial, 15 children in the honey group dropped out because they didn't like the taste and their parents didn't complete the follow-up questionnaires. Now, would you still include these 15 children in your analysis and why? Somebody?
This is called attrition.
Okay, yeah, there is attrition.
They should be accounted in this clinical trials.
Excellent. Why?
Considering maximum attrition rates of 20 to 30%.
Can you tell me what this is called? If you will consider them in your final analysis, what is it called? What is that kind of analysis called?
Contaminants.
No? Yeah, okay. Good. It is called an intention to treat analysis. Okay. So this intention to treat analysis is the participants are analyzed in their originally assigned groups. Why is this important? Because otherwise your randomization has failed, right? Otherwise that balance that has been given by randomization has failed. So it provides an unbiased estimate of the treatment effects, preserves sample size. So there'll be a lot of reasons why participants may drop out of the trial, and that may be important to the trial itself. And therefore, this intention to treat analysis comes of use. So there is something called intention to treat analysis and there is a per protocol analysis. So you can either study them in their originally assigned groups or study them according to what protocol they adhered to. And this group, the randomization is preserved, whereas here there is a bit of a bias, okay, like you said. And here the sample size is also maintained, but here it's a little less generalizable. But this can underestimate the superiority effect if you're doing a superiority trial. In a non-inferiority trial, this might be a little better. This, however, is quite ideal for superiority assessment. You remember there is superiority trials, non-inferiority trials in RCTs. Any questions there?
No.
Okay. So the next one, when preparing to publish this RCT of honey-based cough syrup in children, which reporting guidelines should the researchers follow and why? So there are a few of these reporting guidelines that you guys should know. Anybody?
No.
Priya?
Consolidated standards of reporting trials.
Excellent. Okay, so the CONSORT guidelines, which is the Consolidated Standards of Reporting Trials. It's the international accepted standard, which ensures transparent and complete reporting. And nowadays, this is required by most medical journals for RCT submissions. So this is a CONSORT checklist. This you should know. This is for randomized trials. For observational studies, we have the STROBE checklist, strengthening the reporting of observational studies in epidemiology. And for systematic reviews and meta-analysis, you have the PRISMA, that is preferred reporting items for systematic reviews and meta-analysis. There are many more, but this is a bare basic that you must know. And quickly comparing study designs, we had already completed cross-sectional studies where you measure frequency of exposure and or outcome at a particular point in time or over a particular period. And the outcome measure that you calculate would be the prevalence ratio, and the prevalence odds ratio. In a cohort study, you follow up exposed and unexposed groups over a period of time for development of the disease or the outcome. And you look at the incidence, because here you're following them up. And then you look at the risk in exposed, risk in unexposed, and you can get a risk ratio. In case control studies, you are getting information about one or more previous exposures and comparing between cases and controls. And here you calculate the odds ratio. In intervention study, I was just saying you can do a whole lot of things. It could be absolute or relative risk, risk difference, and odds ratio. A few more things that you could be asked to identify in OSCEs. Can somebody tell me what this is?
No. Forest.
Yeah. Yeah, Sharuk?
Sorry.
Yes.
Forest plot.
Forest plot.
Plot. And forest plot basically reports the results of a meta-analysis. Very good.
Analysis.
We are not going into detail, but please look this up. What is this? What does this look like? No, box and whiskers we already finished last time. That's totally different. This is, what does it look like?
Fish. I don't know.
No. That is different. That is for quality.
Quality.
Fishbone. Yeah. This one, this is called a funnel plot. It looks like a funnel, right? So a funnel plot, this is to check for publication bias. This is again in systematic reviews and meta-analysis. What is this?
Kaplan-Meier.
Yeah. Yes, Kritika, I know you know this, but yeah, this is a Kaplan-Meier plot. This is for survival analysis. Okay. Now, the other topic that I had done last time was immunization. And we had covered immunization practices, vaccine while monitor, freeze watch, other indicators, vaccine storage and equipment, components of vaccine. And we had done 3 vaccines: oral polio vaccine, BCG, and rabies. Like this, you can have questions about any of the vaccines. I just kind of took 3 as prototypes. One question that I hadn't completed last time was about hematopoietic stem cell transplant recipients. So what are the vaccination recommendations for stem cell transplant recipients? Should the donors be vaccinated before transplantation? And what are the vaccination recommendations for solid organ transplant recipients? Can somebody tell me these things? Okay, I think we are nearing the end of time, so I will quickly look at tell you this. So all inactivated DPT, DT, all these things should be given more than 12 months after the transplant. Influenza vaccine more than 3 to 6 months later, but if there's been GVHD, then more than 24 months later. MMR chickenpox, again, more than 24 months later. And if the patient has had GVHD or is on IVIG, then there could be a poor response. Pneumococcal vaccine, 2 doses of PCV at 8 weeks interval, followed by PPV at 8 weeks later. That will be more than 12 months after the transplant. And again, if there has been GVHD, there would be a poor response. What about donors? Can anybody tell me what is the state for donors? Should they be vaccinated before transplantation? Yes, no, what vaccines? Arvind? Priya? Sharuk? Anybody?
No idea.
Okay. So donors should be up to date with routine age-appropriate vaccines. The one thing you must remember is that within 4 weeks of the stem cell harvest, you should not be giving any live vaccines like MMR and varicella. Okay. And there is no reason to vaccinate the donor for the benefit of the recipient. It's just that if you've given MMR or chickenpox, then you have to wait for at least 4 weeks before you harvest. And similarly, for solid organ transplants also, you have vaccination recommendations. Pre-transplant, you must complete all vaccination in accelerated schedule if needed. Complete vaccination with live vaccines at least 4 weeks prior to the transplant. And MMR chickenpox vaccines can be given at least 4 weeks before the transplant. It's desirable to document seroconversion. When after the transplant, you start inactivated vaccine 6 months later. Flu vaccine can be given 1 to 2 months afterwards, especially if there are outbreaks. And boosters can be given as per schedule, or if you're checking antibody levels when they start waning. No live vaccines should be given post-transplant. I just wanted to add this on to the immunization dialogue. Happy to take questions if there are any, especially the statistics questions if you have any doubts at all.
I think the statistics no one gets a doubt.
It was exhaustive, madam. Actually, you have completely covered the whole of statistics and research methodology in this OSCE. It was really fantastic.
Thank you, sir. Thank you so much.
Probably they couldn't observe everything. That's why they are just keeping mum and it was really fantastic session with very neat explanations.
Thank you,
very,
sir.
very neat explanations. Thiru, shall we wind up? Thiru?
I think we can. Sir, I think we can.
Sorry, Murugesh, wind up pannirlama?
Yes, sir.
Right. Madam, I thank you, Dr. Swati and Dr. Kritika, for a wonderful OSCE session. Both the weeks are very, very fantastic. It was a very great learning experience for even a senior pediatrician like me. That's why honestly I accept that. Keep rocking. Thank you. Thank you so much. I thank all the students also who participated actively and avidly. Right? Okay.
Thank you,
right. Anything else to be said?
Also, thank you, madam. Thank you very much for the wonderful session.
Thank you, sir. Thank you very much, actually. So it was very nice to have had some really nice sessions, right?
So I like to thank Dr. Tirumurugan and Murugesh for doing it without any break every month. Excellent.
Thank you, sir.
Very good cooperation. And I was able to complete 12 PG teaching sessions this year. It was really amazing to have like this.
Thank you, sir.
Thank you.
Thank you, sir. My special thanks to Dr. Murugesh Lakshman for organizing all this program, and to President Dr. Palashankar sir for giving us the inspiration to conduct this program. So yeah, definitely next year again we are going to have more of this. So we will continue the same. Thank you very much. Hopefully for the next year we'll continue. Actually, I just hope.
Okay. Happy New Year, everyone.